the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hey, George, it's Tuesday morning and we have a phenomenal repeat guest today. I could not be happier to see him back.
Yes, we have Dr. Brian Birch. He used to be a young Padawan learner. Now he's a Jedi Master, soon to be on the Jedi Council. I'm very excited. I love stories like this. And his topic of discussion is going to be walking the talk to success in independent pediatric practice. Something that's unheard of, but it is there.
Brian is a personable, smart leader, husband, a father, who about a year ago left the big health system to open his pediatric practice. He has encountered great success and joy, and he is also leading by example. He just published his first annual report, which is impressive, and it's the subject of this conversation today. Welcome, Brian.
Welcome.
Thank you. Yeah, thanks for having me. It's a pleasure to be back with you guys and chatting this morning. It's been a wonderful year. We opened up in June of 2023, June 20th, and just about 14, 15 months in, and just lots of success on a personal basis as well as on professionally. So I'm happy to talk with you guys today and share some of our successes.
Yeah, our first podcast was when you just had opened the practice, I believe, or I don't remember.
Yeah, I think we were less than a month open. So I think it was in July of last year and had been open maybe 2 weeks.
I'm excited to hear all the hard work and blood, sweat, and tears that you put into this. I want to hear what happened. Take it away.
First of all, congratulations. Really very proud and very happy for your success, and love that report that you put out, that you're walking the talk, transparency, accountability. That is so enlightening and beautiful to see in a business, but more so in a pediatric practice. So remind our audience, what is Treasure Valley's mission?
Yeah, Treasure Valley Children's Clinic, our mission is to help every child live their most fulfilling life possible. So for us, it's not just about health, because you can have the greatest health and have an accident. We've seen children hurt from not wearing helmets. We see accidental drownings. We see kids with multiple medical issues that may not be, quote unquote, healthy in the traditional sense. So for us, it's helping them and helping families live their most fulfilling life, whatever that may look like for them.
And I'm giddy. Your first KPI in your report is 119 newborns. Why is that the first KPI, and why do you measure that?
Yeah, KPI, key performance indicator, right? So it's a indicator of your practice and what's things that are going on there. And for us, knowing that we're in Idaho, it's a very high growth area. We 51st of the nations for pediatricians per capita. So behind Washington, D.C., Puerto Rico, those statistics. And we're one of the fastest growing areas. But for the success of a practice, you got to have the newborns. Newborns generate not only new patients, but repeat visits. You think about the number of times as pediatricians we see a newborn in the first year of life compared to, say, a healthy teenager. It's significant. So not only is it's an indicator of growth from a growing your practice, it's also a financial KPI, because each one of those newborns has a return on investment more significant than any other age population.
Wow. And then when I look at your stats on chronic illness, it tells a story of how much pediatrics has changed over the last 30 years that I've been involved. Your top 4 diagnoses are attention deficit disorder, autism, asthma, anxiety, and depression. I'm curious to know where diabetes, obesity come into that chronic disease management in your practice now.
Yeah, I would say my practice is a little bit different in the sense that I've had additional training in mental and behavioral health. So I probably close to a decade now ago was part of the REACH behavioral and mental health program to teach primary care providers management of anxiety, depression, ADHD, etc. And so through that, I've really gained additional experience and interest in behavioral health. And in an area that is short of child psychiatrists, let alone any psychiatrist, we've had patients kind of gravitate to getting, in a way, specialty care in a primary care clinic and in a primary care home, which is always our intent, is to, as much as is appropriate we can, we want to keep kids in the medical home and then direct that medical neighborhood for specialty care. As it relates to obesity, yeah, I could throw up numbers of the number of kids that have an elevated BMI. I could throw up the numbers of kids that meet definitions for obesity. But it's one of those things that we do have a program locally for kids that called our lifestyle medicine, pediatric integrated medicine program at the Children's Hospital that can be referred there. I manage a lot of that myself, though, too, through healthy living, counseling, not only during well child checks, but through follow-ups for patients that are engaged in that. And then type 1 diabetes. I do have a few patients with type 1 diabetes. Most of those, though, are managed through our pediatric endocrinologist locally at the Children's Hospital.
So you find yourself sending out the kids with obesity to the specialty clinic, and they have the bandwidth to see them?
No, so I would say that's probably for those that want it or really feel are highly engaged for their multidisciplinary approach that includes dietitian, physician, psychologist, and endocrinology. Those are ones that I tend to refer off. Those that have interest but don't feel that they need those wraparound services, we manage in the medical home through follow-up, through motivational interviewing tactics, and addressing not only the child's health and being and physical activity, but also talking about families' health, being, and nutrition and physical activity. So those statistics I highlighted in our annual report are really things that I don't refer out to. Those are almost every single one of our ADHD patients, minus maybe one or two that came into the practice already established with an outside provider, is being managed in our medical home. Just about every single one of the children living with autism. And one of the projects that we've been working on as a practice is with our state Project ECHO on autism care and STAT training. So STAT training allows primary care providers to diagnose autism in children, mainly because our delay in our wait time for developmental pediatrics, it can be over a year.
Hey, Herb, I have an interesting one. Why don't you enlighten Brian and tell him, when we were young Jedi Pod 1 learners, what was life like then? What were our stats? What did we see? And compare it to what he does.
Root bronchiolitis, ear infections,
cellulitis, necrosis, a whole lot of infection stuff. And all that stuff went away because we did such a good job with vaccinations. We even saw varicella, measles, all these things.
Yeah, you have to be. Every pediatrician was an infectious disease doctor. Yeah, there's just no way around it. And the pediatric infectious disease doctors, they didn't have the bandwidth to see anything that wasn't in the hospital because it was just they didn't have time. There's so much, but yeah, that's all gone. I'm curious if there was a REACH program for obesity and metabolic syndrome and type 2 diabetes in pediatrics, if you would keep more of those patients in your practice.
Yeah, I think we would. I think I've been part of a state quality improvement program that unfortunately dissolved a few years ago around and did focus on some quality improvement around obesity care. So I've been involved with a lot of quality improvement within our state over the last 12 years I've been in Idaho. And so one of them was around childhood obesity and managing it. Sometimes, though, the wraparound resources that can be helpful around psychology, so having a clinical psychologist, counselor, helping with motivational interviewing, having a endocrinologist that can sometimes just reassure family that there's not a underlying endocrinology reason for this, as well as then the nutritionist aspect. So there's definitely room to grow in so many different areas. We talked about it on the last podcast about this philosophy of crawl, walk, and run. At that point, we were in the crawl phase of just getting the clinic up and running, making sure we're providing the basic care. But there's lots of dreams around running with things like obesity and lifestyle medicine. There's a lot of things out there running with other aspects of care that will continue to set our clinic apart, but also continue to provide exceptional care that we feel our patients need and deserve.
Yeah. And then on your report, you put culture up front. Why?
Yeah. So I think with anything that we do, whether that's clinic, whether that's hiring and firing, whether that's your growth strategy or how you're going to lead, I think foundationally, what I've learned is if you have a foundational philosophy of how you're going to do something, you can always fall back on that. And so for me as a clinic, foundationally, it was having a mission that I could speak to and that I truly believe, and then having values that then help with decision making. And so that could be making tough decisions like hiring and firing based upon your values. That can be tough decisions on how do we go about providing the best care that allows us to be sustainable. So when I come to a business decision that's tough, I go back to my values, and our values actually within here are values that are in order of importance. So when I look at our values, our number one value is safety. If I can't do something safely, we shouldn't be doing it. So we make sure that we do barcode vaccine scanning prior to every single administration of a vaccine. We had 0 vaccine errors in the last year, not a single instance of a vaccine being given that was ordered by me that was inappropriately given by an MA. That's one of actually the number one medication errors in pediatrics is vaccine errors, whether a vaccine given too soon or the wrong dose, the wrong medication given. And practices like ours, and I think a lot of other independent practices recognize that and set up systems in place to prevent those sort of errors. But when we go back to that, it allows me, when I have to make difficult choices, to have a foundation to stand on to make those difficult choices. So safety is our number one. The second is exceptional care and exceptional workplace. If our providers and our staff are burned out, they're not going to provide exceptional care. And so we have to make sure that our culture within the clinic and within the organization supports our physicians, our APCs, and our staff. And that comes from my experience as a burnt out physician in a large healthcare system.
Yes. But not everything you've done this year has been a success, right? So you've learned some lessons about hiring and having to let go some people the tough way, which is just being a business owner.
Yep. And there is an executive addendum to this annual report that's not publicly available, where I have outlined those good things, those bad things, and those future growth things, as well as specific business KPIs as well. And that executive addendum is for internal executive use only. That essentially helps that as I do strategic planning for the future and learning, not only for now, but to share as our organization grows into the future of, hey, when we started this up, here's our annual report. These are all the great things we did, but here's some mud and here's the things that I learned from it. And I want to make sure I pass that along to, as George would say, the next Padawan learner of, hey, you have to try to hire, but you're not always going to get it right. So go back to your values. And if you hired wrong, use your values to determine those next steps. And so that executive summary kind of goes into some of that mud, things that we're learning. I've taken this idea from crawl, walk, run to also then incorporate this idea of we are in an area of huge potential for external growth, of growing the clinic and having, at least in these initial phase, pretty big growth strategy that's centered around newborn care. But to support the external growth, you have to have the internal growth of the organization. You have to have the systems in place. You have to have the right people. You have to have those things. But in addition to that, you also have to have the personal growth. And that's my personal growth as a leader, as a physician, but it's also my staff's personal growth too, to look at the personal growth that each one of them will need to do in order for us to be successful. So we focus on those three areas. What's our external growth through marketing and through patient growth and onboarding, to what sort of things do we need to do internally in the clinic to make sure that we can sustain that growth and have processes in place that maintain our culture, our values, and how we want to practice care. But there's a lot of personal growth that goes on with that as well.
Yes. And hiring people is I think, the most difficult job of a leader. It's what makes or breaks your organization, but it's not an easy job.
But if you're a good leader, you will find people because they'll try to emulate you. If you're one of those leaders that is aggressive, degrading, talking down, they're not going to want to work from you. People leave, they don't leave organizations, they leave their leaders.
They leave their
bosses. They leave their bosses. So if you're a good boss, they'll stay.
But there's another component to that. Not everybody deserves a seat in my bus.
Correct.
Because they don't perform at the level that I expect. So,
and I think that comes down to that Jim Collins idea from Good to Great of right seat, right bus, right? You got to get the right person to make sure that they're on your bus. And then you got to find them the right seat on that bus. As a small organization, as a small clinic, it's myself and a physician assistant right now and 3 staff members. So we are small, we are lean. It is even more important to make sure that everybody on the bus is not only in the right seat and oftentimes sitting in multiple seats, but that there's harmony on the bus.
And the bus has to run on time.
Yep.
Yes, I call them the unforced errors. Coach Wooden, as the basketball coach, used to, if his players did not get on the bus 15 minutes before the bus was left, he closed the door. And that was it. He didn't care if he was the best player in the team. It's like, if you can't be on time, I can't trust you to play the way I want you to play. And he made them wear the same socks, the same shoes, and tie their shoelaces the same way. And his philosophy was, I can't control whether we have a better team than the opposition because maybe they had a great recruiting year and you can't help it. They got 3 superstars and I got none. But I can't help that you're not going to get a blister in your toe that's going to prevent you from running fast, or you're not going to have an untied shoelace and you're going to trip and miss a point or miss a movement. So there's things that you can control and things that you can't. The things you can control, you should do them consistently well every single time and have 0 tolerance for doing it. So that when things that you can't control come up, you do the best you can, but you're not going to have an unforced error.
And that's probably the biggest lesson that I've learned, Herb, through all of this is focus on the things you can control. And you can whine and complain about the things you can't control. It's better to do that in private, but things you can't control, you got to move on. So we went through the Change Healthcare payment crisis and our cash flow dwindled significantly to the point that we needed to go into our credit line reserves. Not something that I ever wanted to do or planned on doing. Luckily, it was 2 weeks that we were in there and we were able to pop back out of that stronger than ever. But it came down to I couldn't control that. I couldn't control that I wasn't being paid for the services that we were providing. And so I controlled what I could control, which was making sure that staff was still there, staff was still being paid, making sure that we were still providing the excellent care, knowing that payment would come. And it did. And we were fine on the other end. Had I perseverated on not being paid on the P&L for the months preceding that, it would have been tough. It would have been stressful. And it was stressful, but it wasn't in the way because at the end of the day, you can only control what you can control. And this is something I teach my kids, I teach my patients is you can't control anybody else, but you can control yourself. And so ultimately, if somebody's being mean to you or bullying you, all you can do is control yourself, your actions to other people. And in situations of bullying or other things like that, you can control your proximity to those people. But those same principles apply to running a business is you can only control what you can control. You control yourself. You control your attitude. You control your behavior around other people, even when you're stressed. And at the end of the day, focus on the things you can control and you'll come out the other side just fine.
Yeah. As a business owner, the buck stops with you. So you have to resolve a problem. You need to get funds. Go to the bank, borrow money, go to your bank account, put it in temporarily until the money comes in. You have to resolve the problem somehow. You can't complain about it and say, oh my God, why always me? I get no money from the insurance companies. This technology, somebody else's problem. You got to fix the problem.
That's
what a stat. COVID stats.
A blizzard will teach you that. You get a blizzard that closes down every business for 4 days. and you see no patients for 4 days, that's going to put a dent in your P&L. But there's not a thing you can do about it. And when you sign up to own a business, whatever the business is, you have to be prepared. Something's going to happen.
Yeah.
And if you don't want to deal with it, don't own the business.
It just happened.
I think the chat
here in Long Island, with all this rain that we had, there's two big shopping strips, the left side, the right side. The left side where there's a bakery, a pizzeria, a bank, telephone company. There's 5 or 6 businesses there. Underwater, totally underwater. Water's inside their businesses. They're finished. The other side of the street, they're okay.
You're on the other side of the street.
Yeah, they got lucky.
Are you on the other side?
No, we weren't. We were far away from that. But
yeah, and I think the challenge as a business owner is determining what you can control and what you can't control. As most physicians are, most probably entrepreneurs are, we're A-type personalities. I would say I'm probably an A- personality, but I'm still an A-type personality. But at the end of the day, it's determining what you can control or what you can't control and then letting it go when you can't control it. But I think the hardest thing is recognizing the things you can't control. You can't control that you were on low ground. Maybe you could 5 years ago before you built, but you made a decision or you didn't think about it and you're on low ground and you flooded and you learn. And next time those businesses build, they're going to seek a little higher ground or better drainage.
And Brian, why do you choose relationships over efficiency?
Because I think relationships matter more than anything else, in the grand scheme of things. And that's not just care, that's life as well. I think relationships matter. But I think relationships pay dividends. So when you have a relationship with a family and, say that newborn, you've seen them 6 times in the first year, and now they came back and they read an article in some kooky magazine or online about X, Y, and Z, and they want to talk to you about it. They come back to you. If you have a relationship with them, that's probably going to be a 2 or 3 minute conversation. If you don't have a relationship with them, it's going to be a 15-minute conversation, and they still may not believe you. They maybe go looking for, quote unquote, the real doctor that has the right answer or has the right vaccine schedule that's contrary to what best practices are. We had a family, this is a great idea. We had a family the other day that came in and it said, hey, we're having difficulty breastfeeding. We went to a lactation consultant and they recommended going to the dentist to get a tongue tie release, a lip tie release, and cranial sacral therapy. And we wanted your opinion.
It's all about
we wanted your opinion. Yep. And they came in and we chatted, and that could have been a very long visit trying to talk about how the kid's sticking their tongue out. There's not a tongue tie there that needs to be clipped. Your kid's head is probably one of the best shapen heads I've seen in the last 2 weeks. There's no need for this cranial sacral therapy. If you want to do something, I can send you to a trusted physical therapist that I know and trust that can help with some physical therapy exercises for your child. But I wouldn't do this procedure unnecessarily. I feel like this referral, that recommendation is not in the best interest of your child. It was a quick visit. And they walked out the door saying, okay, good. I'm glad they trust me. They know me. And it actually, building relationships improves efficiency in the long term. Yeah, maybe not in the short term, but in the long term, it builds efficiency. When you need to talk to a mom about all the do this and do that when your kid has a cold because they're a first-time mom and they've never dealt with their child having a snotty nose before. You also know when this is mom's 4th child to say, you know what to do, right? Okay, just make sure if you need anything, I'm here for you. And you might give a quick little refresher because it's been a few years, but not to the same extent. If you try to treat every single patient like that first-time mom, you're going to be spending way too much time. If you try to treat every first-time mom like that experienced mom, you're not going to be giving the education that you need. And so by having that relationship, knowing them, knowing their personality, one, it makes my job so much better, so much more fun because once again, relationships matter, but it also makes it so I can provide better, personalized, targeted care for that child and that family.
Yeah, relationships are great. I believe in relationships. Our practice has been around for 60 years, so I guess we have some relationships. And it is more important than efficiency. But what if you had the relationships and your efficiency is top notch? That's the sweet spot.
Oh, absolutely. Absolutely. But
No.
I don't think this is an and or question. This is an or question. You can have relationships and you can have efficiency.
Yes.
You just need to make sure that
Relationship.
what's driving the cart is the cart driving the horse or the horse driving the cart. I would say the relationship should drive the efficiency because in the long run, the efficiency gains will be there and the care will be better.
I agree with you wholeheartedly. We had one doctor that had really good relationships with patients. His efficiency wasn't that great. So people always waited. This is when we were back on paper. He always did his thing. Once we turned the efficiency on a little bit better with the computers and AI scribing and things, his relationships were still there. Now his efficiency is better. So he made more people happy.
Yep. I'm a little bothered. I don't know if it's just I don't know enough, but along with sending every child with a quote unquote tongue tie for a $2,000 laser at the friendly dentist, which I just tell the parents.
Adult dentists, by the way, our pediatric dentists in our area don't do this. It's the adult dentist that bought a laser.
Why don't you give me $500 and skip the other $1,500? But our sleep medicine colleagues confuse me a little bit. They'll see a more than overweight, 95th percentile in the BMI child for sleep apnea. They'll do the sleep study, and they must have a template because every template comes back the same way. Follow up with ENT for possible tonsillectomy. I'm like, what is removing the tonsils from this kid going to do? He's in the 97th percentile for the BMI. And they also don't seem to screen for any anxiety or depression. There's like, we're going to do the study, of course, because the study makes money. And it just seems like the template always goes back to follow up with the ENT for possible TNA. And I get confused. Is it that because you have sleep apnea, you become obese and depressed? Or is it because you're depressed, then you don't sleep well? That's why you end up seeing a sleep specialist. And is it because you're overweight, then you're more prone to having sleep apnea? And if you don't address those, how are you going to fix it with taking the tonsils?
I think it's from a clinical standpoint, it's all of the above. I think it's a vicious cycle. Kids that are overweight tend not to sleep as well, tend to develop anxiety and depression because of poor sleep and because of other psychosocial interactions. At the end of the day, you got to address all of the causes. One cause may be that their tonsils that they're obstructed, right? And creating a little bit of extra airway motion might be the right thing to do to help then break the cycle. But if you just say, "Oh, I'm just going to remove the tonsils and now we're done and that should fix it," that's not the right approach. You got it. And that's where primary care comes in. The sleep study provider doesn't care about anxiety and depression. They specialize in sleep. The ENT doesn't care about obesity because they specialize in the airway. Now, I think my colleagues, I'm being a little flippant here, my colleagues that do these are great and do care about these things, but it's not their realm of expertise and it's not their realm of managing. I think they recognize the importance and the intricacies and interconnectedness of this. But that's where primary care comes in. That's where we are the intersection for all of these areas or these multifaceted interrelationships. And we know that we can't just address the sleep. We have to address the anxiety and the depression as well. We can't or a lot of times it's like we're addressing the anxiety and depression, but we also have to address the sleep because somebody that's chronically fatigued and tired we have three pillars that is everything that I do as a pediatrician. It comes down to happy, healthy, and safe. And this is something every single well child check. If you look at our templates, you look at what I do, you look at what my physician assistant does. Every single well child check, we talk about happy, healthy, and safe. That's everything. If I was to boil down all of my care, it's those three areas. And sometimes in the newborn or the 2-week-old or the 2-month-old, it's actually talking about the happiness of the mom and the other caregivers. It's doing an Edinburgh postnatal depression screening. It's making sure that they're taking time. As one of my great mentors, Tom Patterson, would say is, you got to take care of yourself as the parent. What he asks, and I learned this from him, he asks every single parent, new parent, again and again, what is the one thing you are doing to take care of yourself with this newborn now in your house? And this doesn't include taking a shower or peeing by yourself if you also have a toddler at home. What are you doing for your own self-care? And that's the happiness portion for that young child, but then healthy and safe always.
Yeah. Yeah. I ask them when are they scheduling their first date with their partner, because the children grow up and you don't want to be like many families. The children go off to college and you haven't been on a date with your partner, and there is your roommates that have tag team their child rearing, and there's no relationship, and then it's all done.
Dr. Patterson, I love his approach, and I want to emulate it, and I should emulate it. And this is a reminder for me to emulate it, is he prescribes to families a date night that has to be completed before the 2-month visit.
Oh, I love that. I love that. I've never read the prescription, but I love it.
And I think it highlights the importance of that. When you take the time to prescribe it as a physician, it's not an, oh, by the way, take care of yourself. It is here's a prescription. Here's the medication that's going to keep your well-being front and center. And it's going to keep your relationship with your partner front and center, is a prescription for a date. And I love that, and something that I think we all can emulate. And he's one of the most fantastic physicians that focuses on ACEs and trauma-informed care in our area. And I learn so much from him every day. And things that I have a constant notepad. And I feel like whenever I sit down with him or in a meeting with him, I sit down and I come away with a list of things to add to improve my care and improve the well-being of my patients.
Wow. How wonderful you have such a mentor in your life.
Yep.
We should get him on the podcast, George.
Yeah, we could. Yeah. Give us the contact information. I'll get him.
And so as far as quality, you use the PTC's dashboard to measure things. And I noticed, and I love it, that 99% of the time you're doing the depression screen. Is that you're following the Academy's schedule of doing depression screening in every adolescent, or?
Yeah, so we, in the Intermountain State area, we have a really high rate of suicidality among adolescents. It's probably one of the highest in the nation. And my work on some state quality improvement really looked at improving depression and suicidality screening within the healthcare system that I formerly worked at, as well as looking at just in our state in general. And the process that I carried over from the healthcare system was every adolescent, every time, irregardless of what they're coming for. And the idea behind that is upwards of 30 to 40% of individuals that complete suicide have seen a healthcare professional in the preceding 2 to 3 months. And it may have been in urgent care. It may have been in the emergency room. Most of those are not mental health, depression related visits, but that is our opportunity to capture and normalize the discussion around our patients, and particularly our adolescents' happiness and well-being. And so we do it every single adolescent, every single time. The reason why it's 99%, I have 2 nonverbal, medically complex, global developmentally delayed children over the age of 11. So it clinically doesn't make sense to fill that out.
So run me through the process. At what age do you start this?
11.
11. And Are you using the PHQ-9? Or are you, and then if they screen in for depression, then do you do the ASQ suicide test? Or
yeah. So we do PHQ-9, so full PHQ-9. And question number 9 there talks about thoughts of self-harm. Yes. And then if that's positive, then I am verbally doing essentially the Columbia suicide screen that looks at, and it's just because I've done this for so long, It's memorized. It's one less form they have to fill out. And I feel like the conversation that I can have by doing that verbally, as opposed to them filling out a form, actually then develops my education to the patient, the parent, as well as the assessment of mild, moderate, or severe risk of, or low, medium, or high risk of suicidality. So I do that verbally because it's part of my essentially safety planning.
Well, that's how you should do it correctly. But this form that you're giving them, is it a paper form and then it gets scanned into PCC, or you're shaking your head?
Yeah. So we laminate. So we try to reduce all the paper in our clinic. So any form that we use on a recurring basis is always laminated, and they have the wet erase markers that they fill out. And then in those situations, we do have Chattis for pre-visit questionnaires for a lot of things. But if they don't fill out the Chattis, or for adolescents, we're just giving it in the clinic, and for the most part, and having to complete it and then addressing it.
I think the relationship is enhanced by you speaking to them as opposed to just, here, fill out this form and let me know.
Yeah.
Talking is important.
I'm going to ask you a tricky question. If you're doing the suicide screening on those patients at highest risk, why are you not measuring that?
That's a good question. We should
maybe just be it's not easy to measure. That would be.
There's ways to do it, and it goes back once again. We're a year open. There's I could show you a laundry list of things I would love to be doing differently, better. I think when making improvements now within the clinic a year in, I'm dividing it into two sections. One are incremental, that 1% gain. If we can do 1% better day over day, week over week, month over month, we're going to continue to improve in those areas. And then there's areas of substantial stepwise change of new processes, new services, new whatever that we need to do. And I think if you don't measure it, then you don't know where you're at. And if you don't know where you're at, you don't know if you need to improve it, or if you don't know that you really did, or to what extent. And so objective data is so important.
The reason I ask you that is because obviously this is important to you. But as we just discussed, when George and I were kids, people died from meningitis. Now the number one cause of death in America, in many of the buckets of childhood, is death by suicide. If it's important, you should measure it, because not only is you're already doing great, but it's about walking the talk, where you're sending a message to your patients, to your staff, to your clinicians as you hire more. This is really important work we're doing.
It is important, but you know what? The patients, the parent, I've had in the past year, 3 kids came in for regular routine checkups. The parents were oblivious to these problems. They left the office, sent to the emergency room, and admitted for 2 weeks with suicide.
Yeah. I mean, it's happening.
Kids, and that's to me. And that's to me. And I usually don't get a lot of the adolescent teenage girls with problems. I'm sure some of the other physicians get a whole lot more.
If you don't ask, they won't share.
Yep.
So you have to ask, and you have to become comfortable at asking. And once everybody knows that's what you do every time, that nobody feels slighted, or what do you call my kid crazy? He always asks that question. He always asks whether we have any allergies or not. He knows we don't have any allergies, but he still asks because he doesn't want to give you, augment and have the kid break out in hives. It becomes part of the process, and people are like, oh, you always ask. So that's what's going to happen when we go in there. But if it's important, then you should measure it, not just from the point of view of improvement, but from the point of view of the messaging you're sending as a leader. I was just curious about that.
Absolutely.
And the other one, I didn't see this because I don't think it's a top of mind, not something, but we do know diabetes now, type 1, is an autoimmune disease. And I find it incredibly difficult to just do it on the kids that are high risk, because then you have to remember to ask, and nobody knows what kind of diabetes grandpa had. Well, I don't know. He had diabetes. He died from diabetes. But did he have type 1 or type 2? I don't know. So to get the kids that are at risk and get them tested is hard. I find it just easier as you're doing with the depression screening. Just everybody at their 4-year-old well child exam, they're going to get the lead level and their anemia screen, get the autoantibodies. And when you pick up the kid, you pick up the kid. But you're not, the process is easier. So I was curious as to why you weren't measuring it. You also make access a key priority. How do you measure access to your clinic?
So unofficially, we will get people in when they message in or call in. So we had 0 patients turned away this last year because of unavailable appointments. So somebody calls in at 3:45 on a Friday afternoon and we close at 4 and they can get here before 4. I've sent my staff home and I'll take care of them and get them in and out the door so that they don't have to wait for the weekend or go to the urgent care. Now, I don't publicize that, but I think access is so important. And I think that is one of our pediatric superpowers that we can have as a organization, is providing access to care. And so we do what's called quick sick in the morning, 8 to 8:30, Monday through Friday, walk-in appointments for any of our established patients for quote unquote quick sick. So we're not tying up the phone lines for the mom that wants to try to get the kid in first thing in the morning because they can just walk in. Parents aren't having to stress like, oh, I wonder if I can get in tomorrow. Oh, maybe I'll just go to the emergency room tonight. They know that they can just walk in tomorrow morning for that quick sick visit. It makes staffing a little bit more difficult. We're going to be going into our first, I would say, busy winter coming up. We were still open less than 6 months for this last winter, so we had the access for it. So it'll make staffing a little bit more difficult, but we're choosing access and then building what we need staffing around that because it's important. Because if kids don't get access to care, then they can't get care. And whether that's access to wellness care in a medical home or access to their medical home for sick care, I can do a much better job because of those relationships that we talked about earlier, managing expectations. Parents come in, oh, my kid has had 2 ear infections this winter. And you're like, yeah, pretty normal. No, you don't need to go to the ENT, the urgent care said yet. Yeah. Here's the criteria. Here's the threshold that we need to do something different.
Yeah. So that strategy that you're using, that walk in between whatever it is, 7 to 8:30 or 8:30 to 9:30, whatever, is extremely well received by the parents. Cuts down
absolutely
the calls at night and the number of people that go to urgent care for exactly the same reason you said. They're not stressed. They know that in the morning they can pack the kid, show up to the office. If they have to wait a little bit, they have to wait. And then it normalizes the rest of your day because now you're running on pre-booked appointments after you're done with.
And we still have open appointments for sick visits throughout the day, same day, next day appointments. So it's not like they have to go to those appointment times, but it's an option for them. And it's an option that is absolutely well received and allows working families to get to work when they just, hey, I think my kid has an ear infection. I need to get them to daycare so I can get to work. They come in, they're out. They're not waiting long period of time. And they're getting care in their medical home.
Brian, how do you solve this problem? When you're a solo physician like yourself, that is a great thing to do. The walk-ins, they just show up. When there's one doctor, the volume is not great. But when there's a lot of doctors that are covering, when there's a lot of doctors and a lot of patient roster, I assure you that the volume is going to be great. And then, because we used to do the walk-ins before, they'd start at 6 p.m. for the evening for the urgent care. People were lining up at the door to come in at 6 o'clock walk-ins. And you know what happened? Physicians started to complain. I can't handle 10 people waiting at the same time, and then all the other drama associated with that. They couldn't pivot.
Yeah.
That's I've seen large groups in my town. I've seen large groups implement this 15 years ago, and they do it in the mornings. They don't do it at the end of the day, because at the end of the day, you're physically and emotionally exhausted. I don't want to see the 4:15 patient that just rolled in the door, because I've already seen 20. So they do it in the morning when you're not physically exhausted. And yes, there's a line out, though, and back when there was all these infectious diseases, there would be a line out. The waiting room wasn't big enough, but they just had one or two physicians who did nothing from 7 a.m. till, I think it was 7 till 9, but to do all the walk-ins. And the rest of them would get there at their regular scheduled time and start going through their schedule. And it worked.
And that's our plan. Is we talked about, do we want to add this same concept to the afternoon as we hit the winter season? We made a decision as a team that, once again, going back to our values, exceptional care and exceptional workplace, we wanted to provide access. We wanted to be there, and we will provide access for those late appointments by keeping schedulable blocks open and double or triple booking at the end of the day on those days that are needed. However, we didn't want to have that emotional and draining, oh no, 4:30, what's coming through the door? I have no idea what's going to come through the door at 4:30 when we do quick sick in the afternoon. Whereas in the morning, it's like I get in there, my TA does it Monday through Thursday. I'm there doing it Friday unless she's out. In the wintertime, I round on the newborns 5 days a week in the hospitals. And so my plan for winter is I'll round a little bit early, and I'll show up earlier to be available to jump in and see quick sick on an as needed basis in the wintertime, knowing that, hey, we might have 5 or 6 people show up. And our goal is we have quick sick from 8 to 8:30. We have a half-hour buffer to get ready for the day. And then 9 o'clock is our scheduled appointments. In the winter, that half-hour buffer is going to be playing catch up. But our goal is to have all the quick six out the door by 9 o'clock for our scheduled appointments.
Brian, I commend you for doing that because that's the right thing to do. Unfortunately, it is old school mentality. And
it is.
And the doctors of today, I got to put little Johnny on the bus at 8 o'clock or 7 o'clock. There's no way I can come to you. And I can't stay after 4. I got to pick up Johnny from the bus. I got to do homework. I got to take the Little League. How many Brians can there be? There's only one.
I think you build a culture, though, and you talk about the importance of it. So I think to that doc, you say, imagine you were a lawyer instead of a doctor, or imagine you were a maintenance worker at a company, and you needed to get to work to pay your bills and so that you could feed your children. And you're reaching out to your physician's office, and they said, I'm sorry, I can't provide you access to care. I think you have to frame it. We are, despite being probably the lowest paid physicians in the U.S. healthcare system, we are still immensely lucky. Yes, we are immensely fortunate.
Yeah.
And I think we have to take our patient's perspective into account and go back to why we entered medicine, why we entered pediatrics. And then you make the decision from a business perspective and a personal perspective of, we're going to let some leakage of patient care out of our medical home because we have to. I don't do phone call. I don't do visits at 9 o'clock p.m. I don't do weekend clinic as of right now, because that's not sustainable for me and my family. Would I love to do that from a patient care perspective? Absolutely. Patients need care on the weekends just like they need care on the weekdays. However, as a small practice, I can't do that. And I tell patients that, and they're like, oh, are you going to open up on weekends? And I said, right now, my focus is staying married and not getting divorced. So if I do open up on weekend, if I were to open up on weekends right now, that my home relationship and home life isn't there. And patients actually, when you have that relationship, once again, they understand it. They want you to be available, and I'm available on call. I help take care of their needs, but I'm not going to have scheduled appointments during that time, this size of our organization, because once again, going back to our values, exceptional care and exceptional workplace, you're not going to be providing exceptional care if you're burnt out because you're working Saturday and Sundays as well as
to your prior point, and you're walking your talk. When we said it's important for you to have a date night when you have a newborn, you're saying the same thing. It's important for me to have a date with my girls and with my wife in order to be here whole to take care of you during the week. If
Yep.
I am not whole, yeah, maybe I can open Saturdays and Sundays, but I will be so miserable that I'm not giving you what you deserve. So I have to take care of myself before I can take care of you. And that is a philosophy that I preach often. It is extremely important to take care of yourself. It's not selfish. You need to take care of yourself in order to give 150% to others. When you don't have anything left in the tank, in your emotional tank, you are of no service to no one, no matter how smart you are. So I commend you for that. That's the way you should do it. I have another question. You put a picture in your report that made me very happy for two things. One of it, we're in DC. And number two, George is not there.
I have FOMO.
He has FOMO.
Major
He's not
FOMO.
there. So why were you in DC and why is it important? And why was that picture important to put into your report?
Yeah.
That's the most important thing, but.
Of course. So I think it's important as part of our values is advocacy. We have, as pediatricians, we are the experts on kids, their health and well-being. And so I was in DC at the AAP Advocacy Conference advocating for really this year's focus was on two things. One being online safety for children. So passing legislative laws around online safety, knowing that the last laws were written in the early 2000s, the late 1990s for online safety for children, and things have changed. So it's having laws that and these were bipartisan laws with sponsorships from both sides of the aisle for that. And then the second aspect was emergency response services with training specifically for pediatrics and being in a rural area where emergency service workers and critical access hospitals may not have a large pediatric population. And that's essential for kids' care. And as a pediatrician, I can have a voice in that. So advocacy is one of our most important things that we can do. And it's why it's one of our values. And so we participated in our Child Abuse Prevention Month. We've participated in obviously the advocacy, and then Voices for Children, which is a nonprofit, nonpartisan organization in our state that really lobbies and helps our legislator try to advocate for good laws and policies as it relates to kids and families. And so with that, I think it's part of our job. It's not a paid part of the job, but it's an important part of the job because we can complain all we want about laws that come down that then we are held accountable for, whether we agree with them or not. But if we're not involved in the process, that's one less thing that we have control over. When I led a work group with a large number of physicians in the healthcare system, really it was after a bunch of bickering about a lot of little things, and we called it rocks. And it's the Muhammad Ali quote that it's not the mountains before you, it's the rocks in your shoes that cause the biggest issues. And so we had everybody for a month, every clinic had a jar. And when a rock appeared, something in their workflow, something in the way things worked, or something they would like things changed, they put a piece of paper with what it was in this jar. And then we brought it together and really set the foundation that there's things that you have absolute control over. And that's the center bullseye. And that's your attitude and your person. That's your attitude and how you treat people. Then there's things that you have a lot of control over, or we as a group have control over. And those are the things that we're going to focus and change. And then there's things that we can influence outside of that. And then lastly, there's things you don't have any control over and you can't influence. And we took all of those rocks and we put them in this bullseye where they should be. And essentially, if it was like, hey, this is a personal thing, work on that. You have absolute control on that. Then we prioritize the things that we as a medical group could control and focused on how we're going to control those and make changes that help us. And then we looked at things that we could potentially influence in the healthcare system. As pediatricians in private practice, we have a lot more control in that control of that bullseye. Once again, absolute control of ourselves and our interactions with people, lots of controls on how we run our practice. But we still want to have that influence because if we don't influence the things that we should, we're just going to get more rocks in the shoe.
Yeah, wonderfully said. Now, why was it important for you to share a whole page of people and companies that have helped you get here?
Because I didn't do this myself. I had people like you. I had my EMR vendor, PCC. I had partners with other vendors and consultants, et cetera, that helped us be successful. So the idea is, yeah, we have a small team. It's me, a PA, and 3 staff. But we have a whole lot of people behind us, not only rooting us on, but helping us. It takes a village to start a practice, and it takes a village to continue to run a practice. And it's acknowledging that it's not just me doing this on my own. It's your guys' influence and contributions. It's Chip Hart and PCC. It's Polly at TMI. It's our OBs that send referrals to me. It's my partnership with our children's hospital that I left, but still refer to and have colleagues there that I respect and rely on for their expertise. It's the village. It's the village to care for these kids. It's my mission is for every child to live their most fulfilling life possible. But I would be foolish to think that responsibility falls just on my back. And it's everybody contributing, rowing in the same direction to get us where we are now and where we want to go.
Wonderfully said. Community is extremely important. Mentorship is incredibly important. Success it looks like it's one person because you're the spokesperson for the organization. But success is in those people that listen to others and then inform themselves and can carry the message so that you urge or you persuade others to follow. And you are a tremendous leader. And
now he's a mentor. So he went from a Padawan learner to a Jedi Master, and now he's on the Pediatric Jedi Council. You have to carry the torch and pass it on and pay it forward.
Yes, and he will.
Yeah, and I intend to. I think I'm the recipient of the Jill Stoller Award within the AAP SOPUM. So I'll be sitting on the SOPUM executive committee as a learner, but with really the intent that I want to give back, because for me, this is the best professional decision of my career after deciding to go into pediatrics, was to live this dream and do this hard work. Seeing the fruits of the labor, even so early in the first year, is so rewarding. And for me, I want others that have thoughts or ambitions for this dream to help them along.
Would you recommend to new doctors or younger doctors or doctors 5 years into academic medicine to go into independent pediatric practice? Is it a good thing?
I would recommend anybody to go into the independent practice, unless you just want to show up, do the work, and go home. If you care about your community, if you care about your patients, and you care about providing the best care, I think that's the recipe to go into independent practice. Not saying that people that work in academics or hospital systems don't care, but if you really care and you want to make the most impact and the most difference, the independent practice route is the best route. If you look at my quality data from 1 year to the next, you asked me a year ago if I thought I was going to provide better care in my independent practice than I previously. And my answer was 100%. My data shows that I became a better doctor by 20 to 50% better in caring for kids by going to the independent route. I didn't become a better doctor. I didn't change. I personally grew over the last year, but having the systems in place, having the processes for care have improved the overall care of my patients and my community. And that's why I did it. And that's why I encourage other people to do it.
So now I'm going to ask you another question. Word on the street has it that in independent pediatric practice, you cannot make any money. It's not sustainable. It's not financially lucrative. Is that true?
No, false. No, it's not true. So I think you have to run a business. You are an entrepreneur. You are a business owner. You have to make business decisions. You have to have a business plan. The first thing I did before I even said, hey, I'm going to go on this crazy idea and open up my own practice was develop a business plan that made sure that I didn't have to sell my house and move to a van down by the river, even though it seems like those camper vans now are pretty cool, that thing. But you got to have a business plan. And so it may be geographically dependent on what opening your own practice looks like versus what joining an established independent practice looks like. But a well-run independent practice can be as financially, if not more financially successful than working for the man.
Do good quality medicine and the money will follow. But if you work for the man and you follow the money only, you'll never do good quality medicine. Yeah. I say that all the time.
Yep. So you got to have a business plan to say, can I make this work? And then you focus on the quality, you focus on the care, and the things will follow. That may not be true 100% geographically around the United States. There are areas where it may be difficult because of saturation of pediatricians and practices where your growth may be extremely slow and you're not going to be able to start up your own practice. But that's where joining an established practice that's well run might be the best option. But I think it's a fallacy to say pediatrics as a whole in the independent realm is not financially rewarding.
And so, so now your turn. Questions you want to ask George or I?
Yeah, I've talked about incremental, that 1% improvement mindset, and there's lots of things I'm doing there. From your perspective, though, seeing my annual report, and I think heard you mention some things around measuring depression or suicidality and interventions there. But what other things would you say a practice like mine should be focusing on in the future?
I'll take that question. I think the next level for you will be efficiency and access to care. You're efficient, but make the efficiency better. And access to care. The morning visits are very important. Maybe you need to get another doctor or somebody. If you get another doctor, expand to a little bit of later hours, maybe even Saturday, Sunday. I promise you, if you open Saturday, you will be full. If you do checkups on Saturday, you will be full. And I also promise you, you will have a hard time finding doctors to work with. There's not another Brian. But Brian has to lead that charge. Brian has to work on Saturday to show that, hey, I'm the boss and I also work on Saturday.
Yeah.
What do you think?
I think that you've done a tremendous job. It's an amazing job that you've done, and you're intentional. You have the right attitude. You have the humility to be a leader. And the next things are just mechanics. And the one thing I tell people, when you're doing well, set some money aside for marketing. Always have money aside for marketing and don't stop marketing.
Yep.
Because we're a business and every business does better when they grow. And the way you grow is by marketing. But you have all the knowledge and the attitude to be a leader. And the other stuff is the easy stuff, the mechanics.
Yep.
Putting the process.
I think the other thing that I'm going to be focusing on this next year is, once again, going back to that external growth, internal growth, personal growth, is internally, we need to systematize things a little bit better. A lot of the work that we've done this first year has been just grit and grunt and getting it done. But now it comes down time to how do we ingrain these results into our workflows that isn't dependent on my grit, my grunt, and that of others, but just as our way of life. And that's the challenge for my personal growth, is how do I systematize that, develop the systems, the feedback mechanisms, the quality assurance to say, hey, when things come up, it's not just, hey, Dr. Birch, what do you want to do for this? Or what do you want to do for this? We have a way of dealing with these things. And that's going to be a future growth. Because as we grow, not everything can come to me to adjudicate. And that's where
gonna happen.
Developing those systems will be up.
As your revenue grows, you're going to have more money to hire more support staff. And there's going to be layers. As the more staff there is, then because you got more revenue, you can set some processes in place. It's hard to really have a lot of processes and workbooks and this and that when it's 4 of you. And people just laugh. It's like, why don't you just tell me how to do it? And then now we know that's how you want it done, and we all do it the same way. But as you get more revenue, you'll have more people working with you. And then these documents and videos and training will become integral to your process. You're doing a phenomenal job. I'm so happy that you're succeeding, not only for you, but for the kids in your community and for the whole country. You're an example of that pediatrics is well, it's alive. You can be a private practice physician, be happy, do good, advocate, and live a great life. That was a dream when we went into this vocation. And it's still there, although they're trying to take it away from us by brainwashing us.
Yes.
But it is a possibility, and you can do it. You can't do everything. You can't. I'm sorry. If you're a woman and you have 2 young babies at home, you can't work 7 days a week.
Oh, it's too
But
much.
if you're a male like you are and you're in a solo practice, you can't offer Saturday and Sunday appointments right now because you got 2 girls and a wife at home that also need your attention. And that's not wrong. That's what you need to take care of yourself. And at some point, you'll have more staff, you'll be able to expand. At some point where you're the primary caregiver for your kids and you're only going 2 days a week to the clinic, the kids are in school and you can go in 4 days. That's what you choose. So remember, in life, there are stages. Just like children go through the developmental stages, we as adults go through the developmental stages. And maintaining a healthy balance is the most important piece of each one of those stages, as you said.
Correct.
The happiness component. Wonderful to have you on the show again.
Yes, thank you, Brian.
We're going to see you in Orlando soon, and I can't wait to get a hug and buy you a beer and celebrate your success.
Yeah, we're going to have a
We talked a lot about my annual report. So if you guys are welcome to link that into your show notes if you want, or people it's going to be up on our website later this week. So
we have to set up a meeting, Herb, with Brian and others for the Pediatric Jedi Council.
Yes.
He's now, I don't know who you want to be. You want to be Obi-Wan? You want to be Yoda? You want to be Mace Windu? Pick one.
We definitely will work on that.
Yeah. All right. We'll call you Yoda, Herb. Thank you.
Yes. Thank you very much. It's great to see you.
Thank you, guys.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.